First one is the total knee replacement. All right, total knee replacement. Okay. In total knee replacement, what is that you're going to do is you're going to cut some part of the femur. So you'll need a femoral component. You're going to cut some part of the tibia. So you'll need a tibial component. And to make both these things function properly, you'll need a liner. So between them, so that is called as the liner. All right. So these are the three basic structures in a total knee replacement prosthesis. Okay. Among these variations are there leading to several types. Okay. The three basic types are the cruciate retaining type. I'll talk. The posterior stabilized type and the constrained unhinged and constrained hinged. Okay. So first I'll explain the different types and then discuss about their significance or clinical values. Okay. Cruciate retaining means what is that? You will retain the PCL, not the ACL, you're going to retain the PCL for added stability. See, here the advantage is since the native PCL is already there, there's going to be less of bone removed. Okay. And there is going to be less tibial post or camp impingement. But the only disadvantage is this offers better mobility. But as the mobility increases, there is going to be higher rate of wear as well in this type of implant. How do you pick this up? In the exam, if it's there, is this the central block won't be there. The central block. Let's look at that. The next one is the posterior stabilized, where you have this central block. That is the only difference. That means I'm going to remove all ACL and PCL. I'm going to stabilize with this block. Okay. This will compromise my stability, but give me more range of movements. Okay. Since the native PCL is intact, the stability is more in this, but I can only do it to some extent of ROM. Okay. Here you see, since there is no native ACL PCL, the stability is slightly decreased, but it gives me increased range of movements and much easier to balance. Okay. So this is the most common performed or used TKR prosthesis. Okay. The big disadvantage is that is this because of this cam, what will happen is this will has a chance to impinge or hit against the femoral component. So that is called as post cam impingement. And that sound when it releases, it calls as patellar clunk syndrome. Okay. So this is the major disadvantage of posterior stabilized, but the main advantage is increased ROM. Here you're going to have more stability. The advantage is increased stability, but disadvantage is increased wear is going to be there because of increased stability, right? So the next is the constraint prosthesis. See, basically what you have to understand is total knee replacement. Although you are doing a bony surgery, you need MCL and LCL to balance the knee. Without them, it is not possible to give a stable knee. We might encounter in certain situations where not by us, the MCL and the LCL will be compromised. In that cases, you cannot usually get away by doing a PS or a cruciate retaining knee. In that case, you will have to put a constraint prosthesis. Okay, the first one in the constraint prosthesis is the constraint unhinged prosthesis. Okay, where you give more stability. Okay, more stability you offer by giving larger, increasing the femoral size and the tibial size. Okay, and the next one is constrained and hinged one. See, hinge is the lock here. This is the most stable one. Most stable but least ROM. Here we are compromising stability with ROM. Okay. The most common disadvantages with both of them is aseptically loosening, because since more of metallic components are there, there is high chance of aseptic loosening. So, if stability you have to rate the implants in order, it would be constrained, hinged, then will be the constrained, unhinged, then posterior stabilized, then cruciate rating. Okay. If you have to rate them for mobility, first one would be the PS knee. Almost PS and CR are same these days. PS, CR are same. And then would be the constrained, unhinged. And then would be the constrained. Okay, this is what they can test you, I guess, with the type of total knee replacement prosthesis, the 4 types. Okay. Now let's move on to total hip replacement prosthesis. Okay. Basically, you have to know that in hip replacement, you have a hemi and a total. In hemi, you replace only the femoral component. In total, you will replace acetabulum and femoral component. Okay. The femoral components, since their origin, how we have to see is the first one, the famous one is the Austin Moores. This is for uncement. How do you identify Austin Moores? It will be a single piece with holes in the shaft for bone pieces. They are used for uncemented purpose. The next is the J.J. Thompson for cemented purpose. This is also a single piece femoral prosthesis, no two pieces, but no holes. This is the historical processes, but trust me, they hold value today also. Okay. They are the Austin Moore femoral component and Thompson femoral component. The Austin Moore femoral component is mainly for uncemented. How do you identify? Is it's a single piece and there will be a 2 holes to fix in bone pieces. For J.J. Thompson, it will be a single piece, but no holes to put the bone fragments. Rather, this will be tapered to use the cement. Okay. So that is the difference. Now, advanced has come the bipolar hemiarthroplasty. Bipolar means this is basically 2 types. Okay. This and the 2 heads, meaning greater mobility and increased stability. The stability is given by outer larger head. Mobility, increased mobility is given by smaller inner head. Okay. So it will be 2 components. This is called as bipolar hemiarthroplasty. They are also of 2 types, either cemented one or the uncemented ones. Okay. Both can be used. All right. So these looking into the femoral components. Now TH. Okay. These are all for hemi. These are all for hemi components. Now, if you look at THR components, what basically you have to understand is along with the femoral component, you are going to have an acetabular component. Based on that, only the famous metal on metal, metal on poly, all that discussion. Okay. Now, basically, if The femur is also metal. The acetabulum cup is also metal, means it is called as metal on metal. In the metal on metal, it is the cheapest one. But the problem is, metal on metal will cause large amount of metal pieces to reach blood and more chance of hypersensitivity reaction and pseudotumor form. Only metal is there. Metal and metal on moving, microparticles, large amount of metal ions can come into the bloodstream, leading to hypersensitivity reaction and pseudotumor. Okay. The next most common used thing is metal on poly, where you have a metallic acetabular cup, a metallic femur component, but like the TKR, you have a poly liner. So this is the advantage is it decreases hypersensitivity, and but the disadvantage is, since it gives better mobility and everything, disadvantages it would cause increased wear. This is the most commonly used is metal on poly. Okay, the metal is activating on the poly. Okay. The other type is ceramic on ceramic. That is the costliest. Okay, this gives the best wear, but easily can break, and you will have a squeaking noise. Okay, so what are the types? Metal on metal, hypersensitive reaction. Metal on poly is the most commonly used, best movements, but increased wear and tear. Next is the ceramic on ceramic, costliest, but maximum movements you get, but easily breakable. That is a very brittle, and it produces the squeaking noise. Okay. Next is the later advantage of that is they have also brought in called as ceramic on poly, where a ceramic head reacts with a poly liner. Two advantages, they have reduced the squeaking noise, but this also has increased wear. Okay, these are the four basic types, that is metal on metal, metal on poly, ceramic on ceramic, and ceramic on poly. Okay, yes. Next comes the shoulder prosthesis. In shoulder prosthesis, you have again two types. It could be hemi or total. In total, you have direct total shoulder arthroplasty or reverse shoulder arthroplasty. What is direct total arthroplasty is the humeral head is as such and the glenoid is as such. In reverse, what they use is the glenoid becomes the ball and the humeral head is replaced with the socket. Okay. In reverse shoulder is most used for where the rotator cuff is compromised, and you use deltoid for the, okay. The rotator cuff is compromised, you use a reverse shoulder arthroplasty rather than a total shoulder arthroplasty. Okay. The next one is the elbow prosthesis, not much advanced there. Okay, this is the basic elbow prosthesis where you have a humeral component and a radial component. Okay, you have a humeral and a radial component. This is very much hinged. Okay, very stable, but decreased ROM. Okay, last resort. This is not as wide or popularly used like the other replacement surgeries. Okay. Now the other, during the classes we have covered several named fractures, but few fractures I could have missed or not covered. So those I'll try to cover in this named fracture session. Okay. The little league fracture is the avulsion of medial epicondyle of humerus. Okay, it can be asked as a little league. If it is for the lateral epicondyle, what is it called? It is called as a fracture of necessity. Why? Increase risk of non-union. Okay. So medial condyle is a little league fracture. The lateral epicondyle is a fracture of necessity, increased risk of non-union. Okay. Piedmont fracture is closed fracture of radius at the middle and distal third junction. That is a by Piedmont fracture. Just know the names only. If it's gonna answer, but hardly it can come. Okay. Barton's fracture we have already covered. It's an intra-articular distal radial type fracture with radiocarpal joint subluxation. Intra-articular distal radius fracture. Okay. Chauffeur's fractures we have already covered. It is a fracture of the radial styloid process. Colles fracture is the extra-articular fracture of the distal radius with a dorsal tilt. Smith fracture is the extra-articular distal radius fracture with a volar tilt. Monteggia fracture is a proximal third ulna. Monteggia fracture is the proximal third ulna with dislocation of the radial head. Galeazzi is distal third radius with dislocation of DRUJ. Hume's fracture is a obliqueron fracture. Okay. Then we could have a Holstein-Lewis fracture. We already saw that. What is an Holstein-Lewis fracture? Holstein-Lewis. Distal humerus with chance of increased iatrogenic radial nerve injury. Okay. Then you have Bennett's fractures and Rolando fracture. Bennett's fracture is simple with dislocation. This is comminuted with the dislocation. Boxer's fracture is the fifth metacarpal head or neck. Essex low precipice is committed fracture of the radial head with the distal radial ulnar joint subluxation. Okay. Coming to the lower limb, you have the Gosselin fracture. It's a V-shaped distal end of tibia, or you can have a pylon fracture. Pylon fracture is comminuted distal tibia injury. Okay. A toddler's fracture is non-displaced final fracture of the tibia for a child. If there is a child with distal radius, it could be a torus fracture. Okay, where you'll have like this, just the bulging of the distal radius. Okay, this is called as a torus fracture. Bimolar fracture is the Potts fracture. Trimolar fracture, Cotton's fracture. March fracture is the second metatarsal head. Jones fracture is the fifth metatarsal base. And we have already talked about the Lisfranc fracture as well. Okay. Some fracture which I might have missed during the regular clinical discussion. Okay. All right. Now coming to important instruments. First is the blades. The blades are like from size 15. The size 15 blade you see only this much. This is for small area. For example, ganglion, lipoma. Okay. And this 11 blade is usually for sharp deep incision. Okay. 11 blade. 10, 20 and 22 for the normal skin incision. I repeat again, 15 is for small area, ganglion lipoma. 11 is for the deep incision, second knife, which we ask for. 10, 20 and 22 are the skin incision knives for normal skin procedures. Okay. Then coming to the scissors, you will have a Mayo curved dissecting scissors. Mayo, you will have a straight scissors. Why dissecting scissors is that you don't poke down. Okay, you lift something up and cut so that whatever is beneath is safe. Okay, very important for fascia cutting. Okay, this is important for suture material cutting. Okay, these are important retractors which are used. The Langenbach retractors for retracting fascia and muscles. Hohmann's retractor is used to retract the whole the periosteum of the bone. Okay, Langenbach is for fascia and muscles, And this instrument is used to strip the periosteum from the bone, used in fractures, non-unions. Okay, and these are the important forceps that are being used. Okay, the bone holding forceps are normal like this, curved. Okay, tissue holding, sorry, a plate holding forceps would be, one end would be curved and blunt, the other end would be sharp. Okay, with this you hold both the bone and the plate. With this forceps you can hold only the bone. And we can never undermine the importance of mallet. You don't call it as a hammer, in ortho you call it as a mallet. To nibble off bone pieces you have the bone nibbler. To scoop out the dust material during debridement you have the bone scoop. And this is osteotome, to take the bone graft. Okay, the most common area where bone grafts are taken is called as the iliac crest. Okay, that is the most common area of bone graft harvestation.